Next on Primary Care, prostate cancer in Black men. Newer research is leading to better diagnosis and treatment.
We're dying unnecessarily, and when we can be treated for this and cured of this disease.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. African American men have a higher incidence of prostate cancer than white men, and also a higher mortality rate. Many studies have looked into the cause and found that disparity may be due to a variety of factors, some socioeconomic and some genetic. Our guest today has conducted extensive research in the many ways prostate cancer impacts African Americans and is here to share this research with us. Dr. Isaac Powell is professor of urology at Wayne State University School of Medicine and the Karmanos Center Institute. His research is in the genetics of prostate cancer development and the influence of race on cancer behavior, particularly in African American men. Dr. Powell is a world-renowned thought leader and prostate cancer researcher and has published extensively on the disease. Dr. Powell, thank you for joining us.
Sure.
And welcome to the show.
Thank you very much for inviting me.
Let's just get right into this.
Okay.
We continue to suffer at a disproportionate rate, Black men versus everybody else, in terms of prostate cancer. Why is that?
Well, there are several reasons for it. You mentioned incidence, and cancer is a genetic disease. Something has to happen to the gene before cancer can develop. Now, the environment can play a role, and probably does play a role, but something has to happen to the gene, and the biology of the body changes such that cancer can develop. So what I've been finding is that the cancer grows faster in African American men than other ethnicities. We published that in 2010. In 2013, we published that there are certain genes associated with aggressive prostate cancer that are more expressed among African American men. And putting those things together, next question is why, and then after that, what are we going to do about it? So, but going back to the question of mortality, there are other factors that have to do with the health-seeking behavior of men, African Americans specifically. We don't go to the doctor as we should. We don't go early enough when they have symptoms, and when it's diagnosed, we're more likely not to be treated than other ethnicities, and we're more likely to choose a less aggressive treatment. All those factors play a role in the death rate from prostate cancer, and what we have learned is that men who are treated, the survival is now beginning to be equalized between African Americans and European Americans. That means when you're diagnosed and when you're treated and you follow up, the survival is much better. But what we also know is the mortality rate has not changed in 30 years in terms of African Americans dying 2 to 3 times greater than other ethnicities. And the main reason for that is the cancer grows faster, it reaches distant disease in a younger age and at a higher rate, and so the mortality continues to be 2 to 3 times greater among African Americans.
So you're saying that if this was a mandate, if treatment was a mandate, we could equalize some of the numbers, at least in areas of outcomes and how Black versus other populations of men do with prostate cancer.
If we got treated earlier and at a greater percentage and diagnosed at a greater percentage. Right now we're aiming to equalize the number of men with PSA testing. What we need more African Americans being tested at a higher percentage and at a younger age in order to impact on the mortality.
So speak a little bit about age and treatment options. You know, we struggle sometimes with who should get what at what age if you're Black versus non-Black. So talk to us about that.
And that is controversial. I'm certainly one who is a proponent for testing African Americans at a younger age, particularly age 40, and whites at age 50. For the reasons I've mentioned, that the cancer grows faster and that there are genetic components that are responsible for that. But there are people who say, well, they don't think that there should be a difference in testing and that African Americans should be tested at age 50. I disagree with that. I think, it should be tested earlier.
The treatment options.
Treatment options, yes. If it's diagnosed early, then surgery or radiation is the appropriate treatment. We did a study in the Detroit area We're part of the SEER group. SEER is a organization that studies cancer outcomes. SEER stands for Surveillance, Epidemiology, and End Results, SEER. And so Detroit is one of the areas, it's one of the areas in the nation that has a SEER registry. There are about 8 or 9 or 10 of those registries around the country. So we're able to measure the outcome of men here. We looked at 8,000 men in the city who were diagnosed with prostate cancer. African Americans were more likely to have radiation therapy. European Americans, we call European Americans, as more likely to have surgery. And what we found out that at 5 years, there's really no difference in outcome. But at 10 and 15 years, men who have their prostates removed had better outcomes. So we know that we've got data to show that the removal is, on the long term, better. Then the other question is, at what age do you treat men? And older men, because the life expectancy is not as long, radiation therapy is more appropriate and in fact, probably indicated. Whereas in younger men, we recommend surgery because of the long life expectancy. So based on age, and then treatment is designed based on that, plus comorbidities, that is.
Right.
If you're not healthy, then if you're 50 years old, then surgery may not be appropriate. Even in those cases, sometimes radiation is not appropriate, and we recommend hormonal therapy. What hormonal therapy does, it blocks the male hormone, which drives the cancer. Don't think it causes it, but once you have it, it drives the cancer. So we want to block that. Like in females, the breast cancer is driven by, one of the things is by estrogen. But in prostate cancer, it's driven by testosterone. And so then going on further with the treatment in terms of advanced disease, one of the first steps is blocking the male hormone. Because now we're not talking about cure, we're talking about prolonging survival. But at some point, the hormonal therapy is no longer effective. And what we then call that is castrate-resistant prostate cancer. It's resistant to the drugs that block the male hormone. Then we don't have any drugs that's effective for increasing survival, and so we're doing research in that particular arena.
What about seed implants?
Seed implants are primarily for people who have low-risk cancer. We grade the cancer on a scale of 2 to 10. We call it a Gleason score. And a Gleason score of 6 is one that's considered a low risk. We don't have any 5, 4s, or 2s that we can diagnose. And the Gleason score is 6, and a person who has a PSA less than 10, then the seeds are appropriate. I'm not one who recommends it for African Americans because we have a more rapidly growing cancer. But it's available, and I present the options to people. They make up their mind. I try to educate them as much as possible about treatment, but the final decision is the patient's.
Dr. Powell, we're going to take a short break, and we'll be right back with Dr. Isaac Powell, Professor of Urology at Wayne State University and Karmanos Cancer Institute.
Hi, I'm Loretta Bush, President and CEO for Authority Health. Testing still remains an important tool in our fight against coronavirus. While many people may have symptoms such as cough, fever, or shortness of breath, some will have only mild symptoms or no symptoms, but still be able to transmit. There are many opportunities to test in our community, including at our Popoff Family Health Center. Call 313-824-1000.
Welcome back. We're here with Dr. Isaac Powell, Professor of Urology at Wayne State University and Karmanos Cancer Institute. Dr. Powell, you have your own personal story dealing with prostate cancer. Do you mind sharing that with our viewing audience?
Of course I will. Back in the early 90s, we had a program where we wanted to educate men in the Detroit area, and we wanted to test them using PSA screening. And so I said to myself, if I'm going to do this, then I should participate in the screening myself. And I did, and my PSA was borderline. And of course, I got a little nervous, like most men do. I repeated it, and it went up. And I said, okay, fine.
What length of time did you repeat it?
In 6 months.
6 months.
Every
okay.
6 months I repeated it because I was, of course, worried about this. And it went up again. I said, okay, it goes up again, I'm going to get a biopsy. I got a biopsy, and it was negative. But I continued to get the PSA every 6 months, and eventually it went up to a level I say, we need to do another biopsy. And did, and they found cancer. It wasn't very much cancer, but this is an important part of this. In African Americans, often the cancer is in such an area that it's difficult to biopsy. And if I can perhaps explain it by saying the cancers that we can feel through the rectum are the ones that we can biopsy easier. However, African Americans were likely to have cancer on the other side, we call the anterior side, which is where mine was. 90% of the cancer was there, and only a small amount was in the area where it's easier to biopsy. So,
did you have any symptoms at all?
I had no symptoms at all. So we published that data. In fact, again, Johns Hopkins published it 2 or 3 years ago, not knowing that we published it in 1999. So anyway, so that was my story of the diagnosis. Of course, I was very upset about this, and I said, you know, I'm supposed to be helping people. I can't help them if I've got it and I have to be treated for it. But anyway, I went through that process. I said, I don't understand why I got it, but eventually it made a lot of sense, because now when I talk to a person about prostate cancer, I tell them if they're having trouble, I tell them, I went through this. I know exactly what you're feeling, and they then feel very comfortable, and their whole body language changed. They look at me, you had prostate cancer, you know? Doctor's not supposed to have cancer.
Not supposed to get sick.
Not supposed to get sick.
That's right.
But here I am having that. So it was much more comfortable for them to make a decision about doing something, more comfortable for them accepting the diagnosis. And so I realize now that's why I had it, you know. I mean, God does strange things, you know, and I don't try to understand them, but apparently that's why I might have had it. So that was my story, and I continue to talk about my story. I have no problems.
How did you handle what we try to help patients through, the relationships with their family, the emotional issues that a patient suffers through? How did you personally handle that?
Well, personally, in terms of my situation, I went and told my wife, and she said, okay, fine, let's get it taken care of yesterday. Women are more concerned about doing something when they have a problem. Men are not.
Yeah, we delay.
Oh, we delay. Oh, yes. But I had a presentation I had to do somewhere, I can't remember now, and I wanted to do that first before being treated. So I told my urologist to treat me with hormonal therapy for 3 months, and then I'd have the surgery. So that's what I did, and I had the surgery. And you know, of course, as a physician, you think the worst is going to happen. Well, none of that happened. I went through fine, and I've recovered, and I'm done well from that.
So, personal testimonial to patients,
yes,
probably makes all the difference in the world.
Absolutely, amazing difference. Yes.
Good. So, on the other side, what are we doing now in terms of helping the community at large get up to speed on prostate cancer? This is not a new subject.
No.
We've been preaching this for a long time now. How are we doing in getting this message out?
I think we're beginning to do well. As I said, in the early 90s, we started an educational program. We went to 51 churches in 2 years to talk about this. We were concerned about what are the barriers? Why are men not coming in? We thought it was about the rectal exam or sexual issues. We found out it was the fear of the diagnosis. They were afraid of being diagnosed because in our community, we think if you got cancer, you're going to die. So we had to convince them that if it's diagnosed early, we can cure the disease. And then we found out that women had more impact on men's health than men do. So we started talking about the women about prostate cancer, and the women actually, men, when they come to my office, they come primarily because their wives told them or their significant other told, you better go get tested.
Well, they come with them.
Oh, and they do come with it. And I insist that the women come because I get the whole story when the women are there that men don't tell. Men don't always tell the truth about their health history. So the women, I ask them, is he telling me everything? And often they add to the story.
Did you change anything personally, your own story? Did your lifestyle change? Did you do anything diet-wise? What did you do?
All those things. I changed my diet. My wife has a healthy diet, but I made sure that I included fruits and vegetables in my diet. Exercise is key. I tell people all the time it is a common denominator for good health, not just for cardiovascular, but for cancer as well. And some of the research I've done in terms of genetics, the expression of these genes that drives the cancer or make it more aggressive, the expression is driven down by exercise. And that was a study found in breast cancer, in fact.
So when we start talking about lifestyle modification to patients, we can now, with some authority, say, listen, you can decrease the incidence or the ability of you developing a malignancy if you exercise, as well as other benefits.
Absolutely. And the other factors in terms of lifestyle is obesity. That plays a major role in all cancers, as well as other diseases such as a cardiovascular disease. And there are fat cells that actually produce these these genes I'm talking about are associated with aggressiveness. And it's the obesity and the belly fat that's primarily responsible for that. Hypertension. I've done studies in metabolic syndrome where the arteries that are inflamed, the hardening of the arteries inflamed, also produce these inflammatory cytokines, immune molecules that cause the cancer to be progressive. So hypertension, obesity are the main factors in terms of our lifestyle. Lipids. Lipids cause the cancer to become aggressive as well. So all those things are important about nutrition and then exercise.
So
Yes.
we're going back to the same old players, the same actors
exactly.
over and over again, and now being able to say that, listen, your activity is going to play a role or a major role in
And
some
we have
instances.
scientific evidence to support that.
Good. What's the role of the primary care physician?
Again, talking to the patient. The question is, how much time do you have to talk to the patient
Exactly.
about all the diseases
Right.
that can impact them? But you can certainly encourage them to be tested for these diseases. And we went through a period of time when the NIH said men don't need to have PSA testing. They were basing it on a research that was totally flawed. They finally learned in 2017 that they were wrong, and now they started saying, talk to your doctor about prostate cancer screening. So yes, that's what primary care physicians can do, is say, I think you should be tested if you're age 40, if you're African Americans, age 50 if you're European Americans. And I use that European version because it's not really the color of the skin,
Exactly.
it's where you're from.
Where you're from.
Exactly.
Yeah.
And as I was telling the men here, that West Africa and Ghana has a higher incidence of prostate cancer than African Americans. And in the Caribbean and in South America, men of West African descent have as high an incidence as men in this country. So it seems to be due to the following the slave trade from West Africa to this hemisphere in terms of incidence of prostate cancer. So the next question is why, and I'm not sure we have time to get into that question because it's complex.
But for sure, if there's no conversation, it's a bad date, that's for sure.
Yes.
We're going to take another break. We'll be right back with Dr. Isaac Powell.
Hi, I'm Loretta Bush, President and CEO for Authority Health. Testing still remains an important tool in our fight against coronavirus. While many people may have symptoms such as cough, fever, or shortness of breath, some will have only mild symptoms or no symptoms, but still be able to transmit. There are many opportunities to test in our community, including at our Popoff Family Health Center. Call 313-824-1000.
Welcome back. We're here with Dr. Isaac Powell, Professor of Urology at Wayne State University School of Medicine and the Karmanos Cancer Institute. Isaac, invariably the question is going to come up in the treatment of prostate cancer with men. Either the patient is going to ask it or a significant other is going to ask that question. We have to be prepared for it. Mm-hmm. Where are we with advising, counseling men in terms of sexual function or dysfunction with prostate cancer?
Sure. Yeah, and that's an important question. Always is. It always comes up. And so the question about the treatment of the disease, it impacts on the treatment of the disease, also impacts on the progression of the disease. Men who have metastatic disease lose their sexual function as well. And men die, and I don't know if anybody dead can have an erection yet. But so, and I give them that perspective. So the question is, what happens after treatment? Yes, some men will lose their sexual function, and it's approximately 50% will lose it that will have difficulty regaining it. And there's treatment, there are multiple treatments for regaining it. But men under 65 have a better chance of regaining their sexual function. Men over 65 have less of a chance of regaining their sexual function. But even for those men, things can be done, such as the implants, penile implants. But for younger men, we start out a month or two after the procedure, treating them with Viagra or Cialis. What that does is increases the blood flow into the penis. And so it's like penile rehabilitation is what it essentially is. It works in some men, some it doesn't. And if it doesn't, there's injections into the penis that increases the blood flow. And there's a vacuum device, external vacuum device that can be placed. That's somewhat cumbersome for some men to use. And of course, the last resort is the penile prosthesis that you can pump up and pump down, have sex on demand. So sexual function can be corrected, can be fixed.
So if we're doing this right, okay, early detection.
Yes.
Start at 40 with screening, okay?
Yes.
Diet and exercise in terms
Yes.
addressing obesity.
Right.
Lipid profile
Yes.
evaluation in terms of the fats that may be producing
Yes.
some of these signals that we see in research.
Yes.
And also, if you do come down with the disease, you're probably going to be able to detect it earlier and have a better response in terms of sexual function down
Yes.
the road.
Exactly, right. No question about that.
That has to be, what should be exciting to a lot of people.
Well, I hope so, but still, some men are afraid of it. I have men that tell me they'd rather be dead if they can't have sex. That's how important it is to them. And unfortunately, men associate their sexual function with manhood. I tell them it has nothing to do with manhood. It's just in your head in terms of what impact it has on your manhood.
Exactly. What can we expect coming down the pike in the future? I mean, you touched a little bit early on some drugs that might be in the development.
For cancer or for sexual function?
Cancer.
For cancer, yes. We have several new drugs out for advanced cancer, and now we're moving it down to earlier stages of cancer, those drugs. And those are drugs that are blocking the male hormone. Some block the synthesis of it. That means the development of the testosterone, that's the male hormone, and there are drugs that block where it binds to the androgen receptor. Androgen receptor is a molecule in itself where the testosterone binds to, and that's what causes the erection. And so if you block that connection, then you can block the cancer development. However, those drugs at some point are no longer effective, and that's what we call castrate-resistant prostate cancer. We really don't have any effective drugs for that stage of the disease.
So the research is continuing.
Oh yes, absolutely.
As far as the community is concerned, you've done a lot of work. You mentioned earlier about the church canvassing that was done. Is it time to do that again?
It probably is, but it takes a lot of effort in doing that. And it's probably something for a younger person to do. I still go, in fact, I'm going to Second Baptist next week to talk about prostate cancer. And I go whenever I'm invited, but to set up a program like we had, it's time consuming and it requires a great deal of effort. But I do it whenever I can. I try to talk to people as I'm talking to you about this and getting the word out. I've done podcasts, I've done videos explaining all the things that we've learned, and I've been in the arena for a long time and learned a lot about what's going on. I should tell you about one of the researches that I'm doing. I've talked about these genes that are associated with aggressive prostate cancer, and we can now measure them in the blood as well as in the tissue. What my next step is developing a drug to inhibit these genes. And so I'm collaborating with investigators at Michigan to do this. And we've got what we call cell lines. We've got African American cell lines now, which we did not always have, where we can test these drugs on. And then we move to the next step in animal studies, mice, and then we move to the next step in clinical trials, which is important to mention because African Americans often don't participate in clinical trials, and we need to, because there are drugs that are effective for whites that are not effective for African Americans.
We learned the hard way with breast cancer.
Yes,
and for years we kind of got it wrong, only to realize because of the lack of enrollment of African Americans in clinical trials, we were treating them properly.
That's right, and there are drugs that work for whites, there are drugs that work for blacks, and we need to know those things.
Yeah, it's probably 12 or 15 drugs that are suspect on the list that says, does this really work for this population?
Exactly.
And that needs to be incorporated, I think, in any approach called research to doing this.
Absolutely.
Yeah, good.
Right.
That's an amazing thing. So let me just back up a second. There are cell lines, you said, related to African Americans and prostate cancer. Do we see that in any other disease states at this point?
I don't know that, but I know we needed them in African Americans because we got these cell lines, but they're not from African Americans, they're from European Americans.
Right.
And so we needed to know what's happening in African Americans. So now we have that.
That's amazing. Boy, we've come a long way with
We have come a long way.
It's like light years compared to where the disease state used to be.
Absolutely.
And what we're able to achieve now. Can we safely say to the general public that black men should not die of prostate cancer if it's handled properly?
Absolutely, no question about it. And I said that back in the 90s. I said, we're dying unnecessarily.
That's where I got it from.
Yeah, we're dying unnecessarily. And when we can be treated for this and cured of this disease.
That's amazing. I mean,
Yeah.
still a lot of work to be done.
A lot of work.
Now, I would be remiss if I didn't say this, Dr. Powell. Just on a personal note, thank you for all you've done for the research community, the medical community as a whole, and what you've meant to young physicians coming along, and particularly African American physicians who looked up to you over the years and becoming the icon that you have become. Thank you for all that you've done for us in this community, and also thank you for joining us on Primary Care today. It's been an honor.
Thank you. Appreciate being here.
Thank you. Our guest has been Dr. Isaac Powell, Professor of Urology at Wayne State University School of Medicine and the Karmanos Cancer Institute. Primary care physicians serve a vital role in health education and prostate cancer screening. They are the ones to begin the process in potentially reducing the impact of prostate cancer in African American men. We may soon see radical disparities in prostate cancer close as more primary care physicians and specialists work together to ensure that all men, particularly Black men, receive appropriate treatment. Thank you for watching. For Primary Care, I'm Dr. Lonnie Joe.